Very good afternoon. I'm audible. Hello. Am I audible?
Yes, sir.
Okay, thank you. So it is 6 o'clock. As scheduled, I will start. And I think
Good evening, everybody. Today we have Dr. Chiranjay talking about melioidosis. And without wasting any more time, I would request him to please begin this class.
Thank you. Thank you, ma'am.
Thank you, Dr. Chiranjay, for taking out time for this.
Thank you.
Any
Thank you very-
questions, if anybody has, they can put it in the chat box.
Right. That will be good.
We can see your slides, Dr. Chiranjay, if you
Yeah.
are ready to begin.
Yeah, fine. Thank you, ma'am. So today, I thanks Indian Association of Medical Microbiologists and especially our madam, beloved madam, Dr. Sonal Saxena, for inviting me for this talk. And the talk is about melioidosis, a neglected emerging tropical disease in India. Though we call it neglected emerging tropical disease, it looks like that it is very newly diagnosed disease, which has never been there. Actually, the story is not like that. And if you know that a disease is older than 100 years. The first publications for this disease is 1912. And it was done by Alfred Whitmore and C.S. Krishnaswamy. C.S. Krishnaswamy is an Indian, and they found this particular disease. That time it was not called melioidosis. That time another disease was there, which is glanders, which was mainly affecting the horses and mules. And while they're working in Rangoon, now it is called Myanmar, they found in a 40-year-old patient's autopsy sample from the lungs, the cheesy materials what they have got, and the patient was a morphine addict. In that patient, they got this sample, the bacteria, and surprisingly, that time the bacteria which was known as Burkholderia malayi. So at first, they thought that it is probably Burkholderia malayi itself. But that is the perseverance of these two people, and they tried to find out, and they found out that this bacteria has every characteristics of Burkholderia malayi, except it is motile. And they didn't ignore this finding, and they understood that they are going to have a new disease. But surprisingly, they understood one thing, that the patient didn't have any connection with horses or mules. So in that case, it cannot be glanders. So the new disease they didn't name melioidosis. The melioidosis name came after a few years. So it is a disease older than 100 years. But the person who actually made the disease famous is not a doctor, physician, microbiologist. He was a detective. And his name was Sherlock Holmes. And the disease that time, it was the adventure of the dying detective by Arthur Conan Doyle, where Sherlock Holmes was chasing one culprit and could not find any evidence against him. So he acted that he was suffering from a particular disease, which is called Tapanuli fever, which he got the disease when he was walking by the side of a river called Tapanuli in Indonesia. And he was suffering from metabolic acidosis and blood-borne pneumonia and severe septic illness with subcutaneous abscesses. And this is a particular typical description of melioidosis. Later, it has been understood that he was describing melioidosis, and that is called Tapanuli fever that time. And he made this disease very famous. So now I come to the point, what is melioidosis? A highly infectious and fatal tropical disease, which is caused by a soil and water saprophyte bacterium, Burkholderia pseudomalayi. Before 1992-93, it was called Pseudomonas pseudomalayi, but then they have understood that there are a lot of differences at the genetic level between these two, and now the new nomenclature has come, Burkholderia pseudomalayi. It is transmitted by inhalation, inoculation, and ingestion, and mostly by inhalation, but also inoculation and ingestions. Most importantly, I want to show you the picture on the side. And I know every one of you might have traveled and you wanted to step in such a field, which is waterlogged, post-harvest. In many places, we got this type of field. We will never know whether this particular type of soil, waterlogged field, is harvesting this water saprophyte or soil saprophyte bacterium. So people who will in contact with soil and water by occupations or maybe during recreational activities are affected by this particular bacterium, by any of these three routes. The disease has two phases. Either those people with if they have risk group under uncontrolled diabetes, chronic kidney disease, chronic alcoholism, or thalassemia, or immunosuppressive conditions, they may present in acute conditions. And they present after acquiring the bacteria inside their body, they present within 2 to 3 weeks. But sometimes their immune system can get rid of the primary assault and they can go into the chronic phase. And there the patient may present with deep organ abscess. I'll come to that. But important point is many of you would like to know that why it is called melioidosis. The word melioidosis has nothing to do with this particular bacteria. Surprisingly, melis means distemper of ascess. What is distemper? Means highly contagious viral disease, especially in dogs, marked by fever and by respiratory and sometimes nervous symptoms. So when the person who called this melioidosis, the Stanton and Fletcher in 1918-19, that time they thought that this is a disease mainly in the animals. And there's a resemblance of the distemper of ascess. Resemblance is there in human being also. So that is called melis, odis, osis, melioidosis, indicating an abnormal condition or disease. But ultimately it is found that not in the cattle, not in animals, it is mostly found in human beings. Now predicted cases in the world, and you will be surprised to know when this paper is being published and the author, and I was talking to him and he told me that I have a surprise for you. And I didn't expect that this would be the surprise. Every time we used to think that the highest burden of the disease may be in the Southeast Asia or Australia, as it has been described in the books. But when the paper has been published, they mentioned that every year, probably, there are almost 165,000 cases worldwide of melioidosis. And almost 90,000 people are dying out of that across the world. Out of them, 45 countries are underreporting who are actually known to be endemic, like one is India. And 34 countries has never been reported, though they are still predicted to be endemic. And South Asia, not Southeast Asia, not Thailand, not Australia, not any other country, but South Asia having the highest burden of the disease, 44%. And out of South Asia, India is the hotspot. You can expect that predicted incidence in India is 50,000 cases of melioidosis every year. And predicted mortality is almost more than 50% of that. So you can understand that how many cases are being missed from India and the other countries in South Asia. India is the hotspot of this particular disease, but we are not diagnosing. We are under-reporting. So I think after this, many of you will know how to diagnose. The Indian scenario, if I want to tell you, the left side of the screen, when this is paper published by me, 2018, there was only 12 to 15 institutions or medical centers were diagnosing this disease. I mean, they are very well equipped, they have the expertise, and they are diagnosing it correctly. But in last 6 years, the number increased like anything. Now it is almost 100 institutions across the country who are diagnosing the disease. Some of the centers, they are sending the samples and the isolates to us. We are now the referral center. We diagnose for them. Some of them are well equipped and they can diagnose by themselves. And many of them have already published. So you can see that in the graph that some of the centers with diagnosed positive cases and published is in the blue color. And those centers in amber color, they are sending the samples to us and we are diagnosing for them. But at the same time, their capacity are being built and in future, they will be diagnosing for themselves. So number is being increased. At present, 16 states in India have diagnosed the disease. And at present, more than 1,000 publications are there. In the community-acquired sepsis, community-acquired pneumonia, or deep organ abscess, or genitourinary tract infections, in this particular disease, out of all patients, last 1 year, we have almost 1,000 patients from 14 states of India we are screening, and we have found that melioidosis incidence is almost 8%. So it is not a disease which to be ignored. Rather, if you look for, you will definitely get the disease. And who are commonly affected? People with long-standing diabetes mellitus or CKD, working barefoot or barehanded in contact with soil and water, especially the farmers, fishermen, daily laborers, in some areas, hunters, and even some people, they prefer to walk barefoot. Many people I met, they walk barefoot for a morning walk on the grass, especially in the rainy season. There is always a chance that they can acquire the infection. And how they get affected? And this is very interesting in that way that in whatever I am mentioning here, in every way, I received a patient, many more that whatever, a good number of patients I have received while working in the agricultural field. Definitely farmers are being affected. While playing or having any recreational activities, I have one boy of 18-year-old who was the single child of the parents, and that boy that year got injuring and he was going to be admitted. He was playing in a waterlogged field in a nearby place and he fell down. And I think he acquired the infection directly into the CNS through the cribriform plate, and he landed up in 2-3 days with high fever and meningoencephalitis. He could not save that boy. The boy died, but it has come into the newspaper. And with that, there was the government of India, a team from NCDC came here, and that is the awareness been created because of the death. And after that, that communicable disease alert has been released for melioidosis for the first time. While working in the barefoot in the soil, or sometimes while gardening barehanded or barefooted. So many people have the gardens in their house, which they do the gardening. Even if you have a tub in your house and there are soil is there, and you are handling it barehanded without any gloves, there is always a possibility. If there is a small cut injuries are there, there is a possibility. While carrying mud or debris on their head or shoulder, many daily laborers, they got that infections. Swallowing contaminated water accidentally. So we had a patient, one man who was drowned, who got drowned during the funeral ceremony of his own father, and then he came here with aspirated pneumonia. And we understood that during aspiration of the contaminated water, he got the disease by swallowing. While facing hard wind blowing in the heavy rain, sometimes the heavy wind is blowing, and along with that aerosols and droplets will be there. And if those are inhaled, there's a possibility that people can get infected. So when the question comes, who is the right patient to suspect melioidosis? And the first point is, and most important point is, anyone with a fever, especially if the patient comes with community-acquired sepsis, community-acquired pneumonia, deep abscesses, especially in the dry season. Most places in India, the dry season starts from the October, November, and it goes till April, May. During that time, most often we get the patients with deep abscesses. It may be liver, spleen, prostatic abscesses, parotid abscess in the children, submandibular abscesses, cervical lymphadenitis, mediastinal abscesses. We can get those patients. Uncontrolled diabetic or other predisposing factors should be there. Soil or water contact may be there. In 80% cases, we get soil and water contact. Rainy season is there, and unresponsive to standard treatment. Many patients may not respond to standard treatment when they come. They may not respond to quinolones. They may not respond to azithromycin or any other macrolides. They may not respond to gentamicin. It is intrinsically resistant. It is intrinsically resistant to colistin also. They even may not resistant to piperacillin tazobactam, or they may be partially responsive to that. So understand one thing: anyone with fever, even they may not have any predisposing factor, still, if you know and if you know how to suspect, you can get the disease. So patient come with community-acquired pneumonia, community-acquired sepsis, cellulitis, deep organ abscess, parotid abscess in the children, prostatic abscess in male, septic arthritis, very common, and osteomyelitis. So orthopedics department, many cases we get with septic arthritis and osteomyelitis. Dermatology can give you the cases with cutaneous ulcer and cutaneous abscesses. Medicine and neuromedicine can give the patients with meningitis and meningoencephalitis. And surgery can give you the deep organ abscess patients. So the patient is not coming to one department, one specialty. It can go to multiple specialty, and you have to keep in track with every specialty, and awareness has to be created. I'll give you an example of one case of ours. It is a very recent one, 54-year male farmer. And he actually, I want to tell you that how misdiagnosis may happen. The patient actually in 23rd of August, the patient came to another hospital with fever, cough, and full body weakness and diagnosed as Pseudomonas aeruginosa pneumonia. Remember, that time he was diagnosed as Pseudomonas aeruginosa pneumonia and treated for a few days with imipenem and piperacillin tazobactam and got released. Again in September, after 1 month, patient again came with fever, chills, and cough with expectorations in another hospital. That time they diagnosed with Klebsiella pneumonia and alcoholic hepatitis and treated again with meropenem, discharged the patient. After a few days, after 10 days, the patient again admitted in another hospital and again got the lower limb pain and got relieved symptomatically. After a few months, in December, patient admitted in another hospital with the drowsiness, jaundice, decreased urine output, leg pain, cough with expectoration, and diarrhea. And before starting any treatment in that patient, he discharged again medical advice. And when in the same month, after in December, he came to us with the jaundice, leg pain, urine output, cough with expectorations, and diarrhea. We found that there is a right-sided pleural effusion in that patient, and along with multiple, because the CT thorax has showed us that multiple centrilobular nodules of varying size and multiple cavitation, which is consistent with melioidosis. So we understood, our clinicians, they are very well aware about that fact, and they told that we are suspecting it probably is melioidosis. And right mild, if you pleural effusions and passive subsegmental collapse of the underlying lung. The patient admitted on 22nd December with type 2 diabetes mellitus, chronic alcohol intake, and GFR is low. And you can see the biochemical and hematological part, and you can see the total WBC is high. So it shows that there are acute infective conditions, and procalcitonin is very positive. And bilirubin is also high, creatinine is also high. And microbiological culture, blood culture group Burkholderia pseudomyeli. So this same Burkholderia pseudomyeli could have been misdiagnosed as Pseudomonas aeruginosa few months back. And that time, if you would have been diagnosed, the patient would have a better outcome. So we have started treatment with meropenem. And then after a few days, we started to ceftazidime because he could not afford meropenem, and we started with cotimoxazole. But again, the patient discharged again medical advice because he has spent all his money. So sometimes we get the diagnosis, but it is always sometimes too late to start the treatment or continue with the treatment, and we lose these patients. So there are many such patients are there. Infections in the medial side of the knee, or patients, and it is not all my cases. I collected the cases across the country. Erythematous nodular lesion, right ankle abscess. A patient, this man is sitting here with chronic osteomyelitis. He came to us and he's a survivor. This lady, 82-year-old, is a survivor for septic melioidosis. This small girl of 9-year-old had cervical lymphadenitis, which was being treated for tuberculosis. And in this girl, from the soil sample from the courtyard of the house, we got the same bacteria, which was, and there's a genomic match. And there is a multifocal osteomyelitis. These are the cases of chronic cutaneous abscess. This lady used to work in a tea garden, and she has chronic cutaneous ulcer. This man had having a septic arthritis. Interesting that when you walk barefoot, sometimes there can have a plantar abscess. So this patient is having a collection, we can say, at the base of the first metatarsal, along with the plantar aspect across the foot, with it deep to the tendons, and it is a likely abscess. And from there, Burkholder pseudomyeli has got. These are all different parts of the India. One patient, the right side corner, the CT suggested malignancy. And when we got the pleural fluid of the patient, we know another institution, the pleural fluid culture diagnosed melioidosis. So these are the varied presentations. If you see the radiological findings, you will be astonished. Vegetations to the tip and the base of the anterior mitral leaflet, would you ever suspect melioidosis? But it is a patient having melioidosis. Mediastinal lymphadenopathy, not tuberculosis, but melioidosis can be there. Bilateral upper lobe pneumonia. Epidural abscess. Most common diagnosis epidural abscess is tuberculosis or Staphylococcus aureus. But here you can see it is melioidosis, can be a differential diagnosis. In the infections, abscess in the liver, in the spleen, there always is possibility. Even in the CNS, you can have interesting finding with melioidosis. I'll show you a few chest X-rays and the CT scans. A 48-year-old male, CKD, fever with cough and abdominal pain, and diffuse haziness of the left lung with CT scan abdomen, hepatomegaly and splenomegaly with multiple abscess. So when in melioidosis, it is not always one organ, but multiple organ can be affected. So when lung is affected, we sometimes don't look for abdomen, but there is always possibility that there is a multiple abscesses in the organs in the other parts of the body. The 39-year-old male, type 2 diabetes, fever since 1 month, old childhood TB, right upper lobe infiltrate without cavitation. And there is hepatic and splenic microabscesses. If the abscess is considerably bigger size, and if it is not drained, whatever treatment has been given, after that the patient may not respond properly. But microabscesses, many times you cannot drain the abscess. In a 54-year-old male, fever with cough for 20 days, had ATT, not responding. Then we understood that this patient is actually having melioidosis, and the CT scan showed necrotizing pneumonia with abscess formation. A type 2 diabetes mellitus patients, 52-year-old, cough 1 month, fever 20 days, well-defined air fluid level with collapse and consolidation. And CT scan showing multiple ground glass nodules in the left lobe with mild pleural effusion. So you understand that these are varied presentations, but if you are not aware, you will never get the diagnosis. But these are all very common, and most often these are misdiagnosed. So when I talk about misdiagnosis, then I should tell you what is the actual diagnosis. Why it is underreported, why it is being misdiagnosed? Because diagnosis is challenging. Where is the challenge in the diagnosis? That I will let you know why it is a challenge in the diagnosis. But before that, I want to tell you one thing. If there is no good clinico-micro coordination, clinicians are not aware and they are not getting actual help from the microbiologist, or microbiology department is not well prepared to diagnose a disease. In that case, the diagnosis will be missed. So first the ball starts rolling from the clinical department when the patient comes and they have to suspect according to the clinical presentations, along with from the area the patient is coming. The first index case is important. If you keep getting cases, you will know that in our areas, the catchment areas, these are the areas from where the patients are coming. Once you suspect, I always recommend that you should start empirical antibiotics, meropenem or ceftazidime, if the patient's condition is critical. If it is a superficial abscess, still you can wait. But patient came with a community-acquired sepsis or community-acquired pneumonia, you should not wait. You should start treatment with meropenem or ceftazidime and send the sample before sample collection. Before you have to start treatment, and then after the sample to be collected and proper sample to be collected. And I always insist that microbiology should visit during the sample collections and see the patients and guide the clinicians which should be the most appropriate sample. It is not one sample. There may be multiple samples. In a community-acquired pneumonia, you definitely respiratory secretions like sputum or ETI spirit along with the blood culture, paired at least 2 bottles. Along with, I also insist, sometimes send us the urine sample also. Many times in the blood culture grew negative sputum, the patient could not cough out sputum, we grew the bacteria from the urine sample. But urine sample processing is little different. Once microbiologists get the sample, they should keep the plate watching for 4 to 5 days, sometimes 7 days. So this is the challenge. We often discard our plates, no growth, and we discard the plate and send the report after 72 hours. But the bacteria may start growing on the 3rd day or 4th day. It may take time to grow. This is challenging. So you cannot keep all the plates. So the suspicion comes from the clinicians. They will inform you, we are suspecting melioidosis. You will definitely look for those plates and you will keep those plates, or even the blood culture bottles you will keep, and you will at least see those very minutely. You will not ignore any growth in those. So blood culture is important. For every suspected patient, if it is a septic arthritis, osteomyelitis, if it is a liver abscess, if it is a pneumonia patient, we always insist blood culture 2 bottles must be there, and it is not one time. One time blood culture may not give a growth or yield. It may be multiple time points, along with sputum and other respiratory specimens, pus, cutaneous abscess or deep organ abscess, you can get that. Swab from cutaneous ulcer you can get. Body fluids, peritoneal, pleural, pericardial fluid you can collect if the patient have that symptoms. Joint aspirate, neurological symptoms along with blood culture CSF has to be there. Many patients with neuromyelioidosis, we get the neurological symptoms along with the growth from the blood, not from the CSF. Biopsy sample is important, but you have to make it sure that biopsy is not sent in formalin. It should be sent in normal saline. Urine, not always, but when no other samples are available, or you are not getting the exact what you are expecting, urine sample is good for the culture, and you may get the growth from urine samples. So in our lab, once the sample reaches, what we do routine culture, whatever is done, blood agar, McConkey definitely, along with the blood culture 2 bottles. Along with that, we collect urine and throat swab. Once upon a time, the lateral flow assay was available. It is still under the process of validations. We validated. It is under the FDA approval now. If we get, it is a wonderful one, which can give the antigen can come antigen-based test, and it can come positive within 30 minutes. Otherwise, if it is a respiratory sample or the skin swab or the wound swab, we put it in enrichment culture CVC50 where there is colistin and as the drug, and we do the PCR. So definitely in all this way, I still don't think 100%, but definitely a good number of patients we are diagnosing without missing a significant one. Once blood culture growth comes 24 to 48 hours. Here, one point I would like to mention that earlier the growth, the more critical is the patient. So if the blood culture beeps within 8 to 12 hours, we always have a suspicion, and we had the experience that we have lost the patient. Culture media to be maintained for 5 to 7 days. Enrichment broth, you keep culturing for 3rd day and 5th day. And we have the latex agglutination, which we have procured. We do that if the growth comes, and we do the AST 3-disc test. I'll come to that. So this is the bipolar stained bacteria, safety pin appearance, how it looks. It is very difficult from the specimen, but from the colonies, you can get this typical look like Yersinia pestis. It is a bipolar stained safety pin appearance bacteria. And it is the McConkey agar. If you see the 3rd day growth, 3rd day you can have the growth, but sometimes on the day 1, very pinpoint, unless there is an expertise, you may not diagnose the particular growth of in McConkey. It is so minute, and sometimes there is other colonies, it can be masked. So it is in the, sometimes it happens in the McConkey that you have to have the expertise. Same with the blood culture. You see the fantastic growth starts coming on day 4. That exactly it is written in the book that wrinkled colonies, it comes in 72 to 96 hours of incubation. So you can see this one, smooth, creamy colonies. And once we have the Ashdown agar, and in Ashdown agar, it is a gentamicin is there. And in that case, you can growth after 5 days, the typical wrinkled growth you can see in Ashdown agar if you inoculate the bacteria. So you have lab should be prepared for this with this expertise and with this medium always. We put in CBC50 broth, and it is an enrichment one. And you can see after the 3rd day, day 2 and day 3, you have a pellicle formation, white wrinkle layer at the surface. And if you culture that, you will grow the bacteria. And even the broth will be little turbid. And here colistin is there. So other bacteria which is colistin sensitive, they will not grow here. But Burkholderia species, not only Pseudomyli, even Cepacia also will grow here. So you have to be very careful about that part. So this is the pellicle formation about this. This is the biochemicals. You should know it is oxidase positive, catalase positive bacteria which utilizes citrate, and it is give oxidative reactions, and it is motile, mannitol non-fermenter, K by NC with no gas, no H2S. And this is the important part. So I will come here, and the routine biochemical reactions and ASTs are helpful, because at least they will help you to diagnose between Burkholderia pseudomyli, Malai, and Cepacia. Burkholderia pseudomyli is an oxidase positive, oxidative, non-saccharolytic, reduced nitrate to nitrite, no H2S, no gas, does not ferment mannitol, motile, utilize citrate, does not hydrolyze urea, but dihydrolyze arginine. So amino acid tests are important. And if you have to know how to interpret and how to prepare and interpret amino acids in your lab, it is sensitive to amoxiclav. That is very, very important one. And resistant to gentamicin and colistin. How important it is, I will let you know after a few slides. Amoxiclav sensitive will give you the diagnosis. This is the latex agglutination we do with monoclonal antibody and exopolysaccharide of Burkholderia pseudomyli if the colony comes. Once the lateral flow assay we used to do, wonderful test. We have a paper published out of that. And even from the non-invasive samples like urine, 1 drop of urine can give a band, and you can find out that it is probably Burkholderia pseudomyli. It is under the process of evaluation and validation and FDA approval. I expect that by the end of the year we can get this. And this is the 3-disc test. Gentamicin, amoxiclavulinic acid, and colistin. Burkholderia pseudomyli is amoxiclav sensitive, gentamicin resistant, colistin resistant. Cepacia, which always get confused with Burkholders's pseudomyeli, amoxiclav resistant, gentamicin resistant, colistin resistant, all three resistant. Pseudomonas aeruginosa, amoxiclav resistant, genta sensitive, colistin sensitive. So with this three disc interpretation, at least Burkholder's pseudomyeli, cepacia, and Pseudomonas aeruginosa. Pseudomonas aeruginosa is pigmented, you need not have to bother about. If it is non-pigmented, or if any other species of Pseudomonas, sturgeon, putida, in those cases, you have a confusion. These three discs will help you to diagnose Burkholder's pseudomyeli. Along with this, we test ceftazidime, meropenem, and cotrimoxazole. Commonly misidentified, even in the automated system, are Pseudomonas aeruginosa, Burkholder cepacia complex. You can see the whole complex here. Thailandensis malai gladioli, Pseudomonas sturgeon, Stenotrophomonas maltophila. It should, if the automated systems gives you Stenotrophomonas maltophila, do one oxidase. It will be oxidase positive. It cannot be Stenotrophomonas maltophila. Ralstonia piqueti, Ralstonia other species, even aerobic spore-bearing bacteria. Many times it has been told to us that if a bacteria which is wrinkled colonies in the and after 2-3 days it is growing, probably it is a lab contaminant. May not be. It may be Burkholder's pseudomyeli. And if you diagnose, you can save one life. So that is very important in this matter. If we don't diagnose, what can be happen? Wrong diagnosis give wrong treatment. So the patient will keep on getting wrong treatment and keep on coming back, may not to you, to your hospital, some other hospitals. Prescribed antibiotics like ciprofloxacin or quinolones or the piperacin tazobactam may be partially working, or gentamicin may be intrinsically resistant. You will not get enough response. So appropriate antibiotics are ceftazidime and cotrimoxazole, which are not costly, available, and can be given and can save a life. If not, patient will keep coming back with relapse or more severe complications like sepsis and may lose life. Most importantly, if we get one case, we can, and many more cases, we can find the locality or the regions from where they're coming. And next time when they're coming from the same locality or regions, you can identify or you can suspect at least. But if you miss the cases and keep missing, you will never identify the locality. So treatment is difficult because not many organisms in microbiology we treat like that. Like we treat sometimes Mycobacterium tuberculosis, long-standing treatment. Here also, there's an initial intensive phase where we treat for 10 to 14 days with ceftazidime or meropenem. We treat them for 10 to 14 days, but 10 to 14 days is not fixed. It can be 1 month or 1.5 months or even 2 months if the patient is very complicated and serious, especially neurological melioidosis, joint melioidosis. In that case, sometimes you have to add cotrimoxazole also. Patient is having problem with cotrimoxazole, you can add doxy or amoxiclav also. But once you discharge the patient, this is the most challenging part, and where we all fail is that oral eradication therapy for 3 to 6 months. The patient should be given oral cotrimoxazole and ask the patient to take the tablet. Most often, after 1 or 2 months, they stop. The compliance is poor. And then they come back with relapse. We have few cases of relapse. Patient came with one organ infections, and then after a few months, they landed up with another organ infection. And always that they have not continued the treatment. So this part is very challenging. Prevention, there is no vaccine. But we are working for the vaccine. In future, I hope the vaccine will come. Again, whom to give vaccine, that will be a question. High-risk people may be given the vaccine, like farmers, laborers, fishermen. We plan, and Thailand was trying to teach them to use well-covered footwear and gloves, but they failed. Very difficult. The farmers, they refuse that we don't want to wear footwears while working in the field or gloves. Drinking water may be boiled. So that is one point. Otherwise, ingestion is the root. Washing hands and feet with soap and water, even after you are doing gardening at home, and don't come back to home without washing hands and feet with soap and water. And during heavy rain, strong wind is blowing, we should use mask. It can prevent infection. In Corona period, the infection rate has come down. Everybody is using the mask. So last part of this, I will come that we will have a mission ICMR task force project where we are taking the 14 states and 15 centers in India, where we are building the laboratory capacity and clinical awareness. So at the end of 3 years, there will be a self-sustainable model in each those states who will be designated as the nodal center. And those centers are well equipped for phenotypic and genotypic detections of the bacteria, and their clinicians also will be aware to guide the treatment. So they will now further train, and it will percolate further. So this is a capacity building project to initiate and strengthen the clinical and laboratory detection of melioidosis in India. And it is with ICMR. So you can see this area, which are the states and which are the centers we have that. And these are across the country. Most of the 7 centers are from Northeast, 8 centers, and rest of the centers are from different parts. So from Delhi, from Rajasthan, from Odisha, from Madhya Pradesh, from Karnataka, and from Kerala. These are the different states are there. And out before including those states, these red bordered states, they're already diagnosed melioidosis. So they have been included. After including these states are Rajasthan, Delhi, Assam, and Tripura, they diagnosed melioidosis. And still there are some states are there that are yet to diagnose, but I think that they can diagnose any day. Even from Delhi, environmental sample from the soil, we got Burkholderia pseudomyeli. So it is spread across the country, and this is the task force project. We do the laboratory capacity building, clinical awareness, molecular epidemiology. Along with that, once we do the molecular epidemiology and clinical awareness and laboratory capacity building, we will go down to the primary healthcare center and secondary healthcare center, which have already started. And we are making them aware of the disease. And we're asking them, if you suspect a patient, either you treat like this or send the patient to the tertiary care or the nodal center. After that, we have a plan for environmental surveillance, that is the soil surveillance and water surveillance, and along with the sero surveillance, we are planning to do. So, the Indian scenario of melioidosis. Till now, more than 1,000, now it will be 1,500 cases has been published for last many years, 3 or 4 decades, but it is very less in number than it was supposed to be. The disease has been diagnosed for 16 states of India. Recently, we got the cases reported from Gujarat, Rajasthan, Tripura, Assam. And we are expecting that there are many other hospitals in many other states. They keep sending samples to me or the isolates to me, and we keep diagnosing for them, and they're treating the patients. And we always make one slogan: one diagnosed means one human life saved. So you understand that still now, more than 500, 600 patients we have diagnosed, and out of them, if the mortality is 20%, rest of the lives has been saved. It has a huge mortality, sometimes 50%. Out of any 2 patients, 2 can die. So in our project, I have totally telling you, 8% is melioidosis in community acquired sepsis, pneumonia, and deep organ abscess. And mainly the vulnerable socioeconomic status people, farmers, fishermen, daily laborers, they are mostly affected. But we have patients who are school teachers, we have patients who are doctors, we have patients who are businessmen. So it is not only the vulnerable socioeconomic status, not only the diabetic populations, non-diabetic and high socioeconomic status people also are getting melioidosis. Mortality is high, 20% I am average, but it's sometimes in some institutions it is 50%. So the project is India may have the highest burden as it is predicted. As it is predicted that India is the hotspot of the disease, probably that is true. We are going to find out that. And if we are not diagnosing, means we are missing patients. If you diagnose one, you are saving one life. And why you are not diagnosing? Because there is lack of awareness. If we are aware enough, we can diagnose many more numbers. So first starting point is laboratory preparedness. and that we have started. And many other laboratories already prepared now in every state, and they are properly diagnosing and they are treating their patients. And clinicians should be aware of the disease. It should come in the differential diagnosis of community acquired sepsis, community acquired pneumonia, deep organ abscess, genitourinary tract infections, not urinary tract infection, not lower urinary tract infections, but it may be coming as a kidney abscess, pyelonephritis. So in the project mission, we are working now, it will ultimately create the awareness, build the laboratory capacity. They will create more number of patients will be diagnosed on these centers. More number of centers will be taken in future maybe, and each center will be the nodal center from their own state. So thanks again to Indian Association of Medical Microbiology for giving me the opportunity, and I'm very grateful for that. I'm thankful to Dr. Sonal Saxena. Madam called me and asked me, and I'm very grateful to Madam that she has thought about this particular disease, which is neglected, that it is very, and she asked me to talk to the PGs, who are the future torch bearers. And you will lead microbiology in future. So you should know how to diagnose it. And you should be an expert in this disease. So I'm very thankful for this opportunity. Our lab center for emerging and tropical disease, now the ICMR melioidosis referral center. We have a lab now for not only diagnosing melioidosis, any PG wants to do their work, research work, or do PhD in future, or want to get trained, or want to know, they can step in, and we are very happy to accommodate them. So this is a lab for everyone to get to understand about melioidosis, get trained, and diagnose and save life. Thank you very much. It is because it is for PGs, so I kept 5 questions, and down is my email address. So these questions is, please, you can note down, any one of you. It is optional. Any one of you, if want to write the answers and send to me, please send to me. I'll be very happy to answer, and I will be very happy to keep in touch with all of you. Thank you very much.
Thank you, Dr. Chiranjay. It was an amazing class, and the way you took it, it made it very more interesting. I will now request Dr. Bharti, our president, to please give some closing remarks.
Thanks a lot, Sonal, for organizing this. We really chosen a good topic. And Chiranjay, you really done an excellent work and very well presented. And really like how you explained the clinical scenario and how we are missing these diagnoses. Because in routine, we are not incubating that long. And we are just having these kind of clinical presentation and many times giving ATT or some other chronic infections we consider, and we really miss this diagnosis. So I think it was really an eye opener to me also, because this is actually a neglected disease, and you've really done good work on it. And it is good to see that many centers you have roped in and created a good network. So that will really make people aware, and we head more towards diagnosing all these unidentified diseases. So thanks a lot, Chiranjay. It was great presentation, and we really look forward to. I can see AIMS Jodhpur has been in Rajasthan.
Yes,
and practically throughout the country you have centers you identified. So in just a line, what would be the message you would like to tell the microbiologist? Like many times clinician may not give the history. So should we incubate all samples for long, or just what would be the way forward, a simplified way forward for the routine microbiologist?
Right, ma'am. That is a very good question, actually. That is the question, actually, to PGs should know that the first, if you start from the lab, first thing, you have many cases where it is not Pseudomonas aeruginosa, but Pseudomonas species, and which are maybe, if you do the gentamicin, and you will see that they are gentamicin resistant. Any such occasion, if you encounter any such situation, in that case, that is the first starting point where you may be missing melioidosis. Even the automated system can give you a wrong diagnosis. That is the first point. Second point is that in any such conditions, you should have an amoxiclav disc. So amoxiclav, gentamicin, and colistin, if you 3 discs, if you put, and if you say amoxiclav sensitive, gentamicin, colistin resistant, probably you are handling melioidosis. That is the very easy way to do in the lab for the PGs, and that is the starting point. Other than that, many times the patient, madam, you know very well, many times the sputum negative or the smear negative TBs, still they are treated with anti-tubercular drugs. And those people, we got many such patients. One school teacher, headmaster, ultimately we could not save him, but 4 years they have got the ATT, he kept on giving, but ultimately we diagnosed as melioidosis, but never TB been diagnosed in him. So any such smear negative TB to be again looked for melioidosis. Melioidosis come as a differential diagnosis for that purpose. It should come. This is a very important message I want to carry. So it is that we are maybe melioidosis we are encountering. I don't say every day, but definitely sometime in our lab we are encountering and we are missing those. So keeping the plates for longer durations, but you cannot keep all plates. So in that case, you need a clinical microbiological correlations. Your clinician should aware of the disease. You can make them aware. And if they suspect any disease like that, they can let you know. Maybe it may not be the diagnosis, but once they start suspecting, I'm very sure that in your lab, you will get melioidosis soon.
Because as I'm looking after the TB lab, and we do get many cases like that, TB suspected, gene expert negative, culture negative. So, are there good molecular tests like to go for in the sputum sample?
Yes, ma'am. Those samples, if gone for the PCR, we have the PCR here. We have we have the PCR which is very specific for diagnosing melioidosis. So that PCR can be given, and this is not a very difficult, just like any other PCR, it can be done, and that can give rise to melioidosis. And if the routine culture also of those samples sometimes give the growth.
Okay, good. So, because routinely we are doing the DNA extraction, the TB lab,
Yes,
so one can put that sample to
right.
PCR for melioidosis. That's a good thing because sometimes when you are really looking at the clinical history and following up the patient closely, so that would be a good choice to do. So, thanks a lot, Chiranjoy, and thank you, Sonal. We look forward to such more PG classes, and that's really a great activity.
So there is a question for you in the chat box. Is Malditov validated for identifying pseudomyeli? This was my question also. Because most of the time what happens is whatever grows, we put it in Maldi. So once you have Maldi, you don't think of anything else. So
Yes.
What is your experience of this?
Our experience is Malditov is not validated for detecting Burkholderia pseudomyeli, but out of 10 cases, you can in 6 to 7 cases you get the Burkholderia pseudomyeli diagnosis. But there are 2-3 cases will be there. It can come as Ralstonia. Sometimes it can be Burkholderia cepacia, very commonly Burkholderia thailandensis, Burkholderia vietnamensis, Burkholderia multiflorens. Different types of diagnosis it will come. So in those cases, definitely we should look for melioidosis. Burkholderia, I mean the Malditov. I think now USA have their cases of melioidosis started, and they are very much cared about melioidosis now. And they all not only having the patients, but also from the Mississippi River Bay, they got melioidosis from the Burkholderia pseudomyeli from the soil sample. So CDC is now very much alert, and I think that the database will be improved now, and Burkholderia pseudomyeli will be included into that. But till now, it is not there. I mean, you may get the diagnosis, but may not also.
And what about Vitek? You get
Yes, Vitek is better. Vitek is better than Maldi. Vitek will get out of 10 times, 8 times, you will get the correct diagnosis, but there is always a chance of giving 2 times there is a misdiagnosis possible.
Because I do remember there was a time when many cases, some contamination in some drug was there, and we got a lot of positive. So we were just wondering what's happening out there. So from the Vitek we got that.
Yes, yeah.
Okay. Another thing, it's just to add on actually what ma'am was saying and what you said. Probably what happens is that centers like maybe Jaipur or Delhi, our issue is we tend to have a very urban outlook to our patients. We always feel there are no horses here, there is no connection with soil here, there are no farmers here. So probably we'll not be getting these kind of patients or any of these zoonotic diseases. But lately, I have seen in the past 2 to 3 years, there is a lot of migratory population which comes into the cities. They travel for health purpose only. Suppose they are on ATT for 6 months, 8 months, and they are not getting cured. they say, okay, let's go to Delhi or let's go to Jaipur or let's go to Mumbai and get ourselves treated. So I think keeping an eye open is very, very important, particularly if you have a history. Recently, we had 3 cases of JE, and it was a kind of a national disaster that you have JE in Delhi. But then we found out that all the patients were actually from Bihar who had traveled to Delhi to get treated. So I think that would not have happened had they been negative for JE, but because they were, the system of IHIP is built in like that these days. And you've answered another question which is my favorite questions. Many of my PGs are also logged in. I keep asking them what is the DD of wrinkled colonies on blood agar, and they don't go beyond ASBs. So today you gave them an answer.
Yeah, thank you. Yes.
Thank you so much, sir. Thank you,
Thank,
everybody, for joining in, and thank you, Dr. Bharti,
thank you, ma'am.
for this. And we'll continue our endeavors once a month.
Yeah, thank you
Great,
very much,
great.
ma'am. Thank you. It's my
Thank
pleasure.
you. Thank you so much.
Thank
Thank you.
Really, really an eye opener for me.
Thank you.
We're not doing bacteriology routinely.
Yes, there are lots of good and complimentary comments for Dr. Chiranja in the chat box.
For you too.
Thank you so much.
Thank you very much.
For you too, Sonal.
Thank you. Yes, ma'am.
Great job.
It's a great effort.
I'm a postman.
A very efficient, proactive. Thank
Thank
you.
you.
Okay, bye.
Thank you.
Okay. Bye bye.